So this is going to be a brief case presentation on this session regarding tricuspid and pulmonic valve disease. We're going to have 3 speakers and a panel discussion, and then 3 speakers and another panel discussion. I'm going to be the first of the second session of the clinical presenters. So before me, we'll have discussion regarding diagnosis, mechanism, prognosis of the tricuspid regurgitation, and how to manage it, basically. And then I'm presenting this case. That's the title that was given me, which is normal ventricle and large atria. We'll have a case of Epstein anomaly, and then we'll have surgical approaches and interventional approaches for right-sided valve diseases. My allotted time is 9 minutes. I'm going to try and stay within 8. And again, the panel discussion will be done at the end of it. So this is the story of PW, a 68-year-old African-American woman that was seen in the emergency department complaining of sudden onset of palpitation, shortness of breath, and chest discomfort after her dialysis session. Her vitals are there, so when she was seen in the emergency department, her heart rate was down to 85 with a rhythmic pulse. Her past medical history is significant for long-standing hypertension. She's an end-stage renal disease patient on hemodialysis twice weekly. And her sessions are usually complicated by onset of severe hypertension. She always has diabetes, and she has a past medical history significant for severe bleeding due to a diverticular colic disease that had been treated with multiple transfusion and had requires a previous embolization of sigmoid branches in the inferior mesenteric artery. That, however, did not resolve the issue, and she's going through hemodialysis without heparinization of the circuit. So on the emergency department workout, she had a transthoracic echo done, which we are seeing here. I'm sorry if the loops is not looping. That's the issue with my computer. It will be fixed. So here we see basically the parasternal and the apical fourth chamber. I just want to point out the fact that the patient is in sinus rhythm with normal LV and RV function and a significant increase on both right and left atrium volumes. A closer look at her tricuspid would actually show significantly reduced coaptation area, and the Doppler, both with a continuous wave Doppler and color evaluation, was consistent with a moderate to severe TR. That's what it was called in the report. So the patient was hospitalized. She was monitored overnight. She was found to have some non-sustained ventricular tachycardia. She underwent a stress test that was negative for ischemia and was dismissed after the initiation of a beta blocker therapy. She did not have any cardiovascular contact for the next couple of years, but she was seen again by a cardiologist in 2009 for a new hospitalization for tachycardia, again during her hemodialysis. She did not feel palpitation of shortness of breath this time, but her EKG this time showed a clear AFib with a heart rate on the 120s. Her vitals are there, and so by the time she was seen in the emergency department, the heart rate had gone down in the hundreds. And again, I'm showing you here basically the mirror images of what we've seen before, which should be playing, but they're not. Again, normal LV and RV function, AFib this time, and a new increase or worsening of both LA and RA volume dilatation. Looking at her TR, modified parasternal long axis here, we see reduced coaptation area, enlarged diastolic, enlarged annulus, and a color Doppler, which is significant for severe TR, as it confirmed by the Doppler analysis on the subhepatic vein flow, showing here a total reversal of the systolic flow here. This time, the patient was treated with diltiazem. The story goes that she had stopped her Sotol, so the beta blocker therapy, because of excessive hypotension during dialysis. So she was not treated at this point for her AFib. She was started on diltiazem and was dismissed with diltiazem and digoxin combined. On the following year, she presented multiple times in the emergency department complaining of the same issue, so basically tachycardia during her hemodialysis session. And she was hospitalized once more in 2010, admission for a septic issue, so she had pneumonia, and was found, of course, in that context to have, again, atrial fibrillation with a poor rate control. And this time, when they looked at her art, the figure that we have is totally different. So now I hope you can appreciate the reduced RV function an RV which is dilated and not really contracting, and on the apical four-chamber, a color Doppler which is striking for severe TR. And a closer look at her tricuspid valve would show this time a wide open TR with no opposition whatsoever, a severely enlarged tricuspid annulus, and as we said, an enlarged RV with reduced systolic function. During her hospitalization this time, the AFib was addressed and she was deemed to have an AV node ablation with a PM implantation. The procedure was successful. The patient was dismissed in rehab, and unfortunately, we don't have a follow-up because she was lost to follow-up after the procedure. But what was kind of striking going through these different charts and different consults was that even though there was a clear focus on the AFib management, there was absolutely no mention of tricuspid valve pathology, but of course on the echo reports, and no discussion whatsoever of what should be done to address the issue or of an ideal interventional planning. So I will not go through the background of that because Dr. Badano has already showed you this figure. I just wanted to mention that in this evaluation of the impact of severe functional TR on a general population, the prevalence of patients with AFib is as high as 44%. So this is not a trivial issue. This is something that many patients are actually facing. And AFib, connecting AFib and TR is actually something that has been done for years. We have figured out somehow a specific mechanism for which AFib and functional TR are connected, which involves basically directly the dilatation of the tricuspid annulus, specifically in its free wall portion, which is the weak point of the whole annulus being far away from the strongest point of the aortic mitral fibrosa. And that chronic atrial fibrillation per se, even without the involvement of left heart pathology or pulmonary disease, can lead and can actually be connected to tricuspid regurgitation, which in turn, causing a chronic volume overload, would actually be able to increase and worsen the tricuspid regurgitation per se. Thank you. I've got 7 on my timer. Correct. That's my computer, because the videos are huge. So I'm hoping that running on a different computer, which should be more powerful than mine, there shouldn't be issues there. They all should be looping, and they all should start automatically while I open the slide, so without having the need to click it. I'll try on another computer just to be more powerful and just to be double sure.
Can you go back to?
Sure.
The first one was not convincing. The first picture of the TR that's called moderate to severe TR.
Yeah. Not convincing in this.
You have to kind of bring something else. Go back to the beginning. I think that's the one.
This one, yeah.
From this view, so you have to, somebody has to mention that it was not a CDR, maybe better do what you see.
Yeah, I use this one.
It's very eccentric. I don't have a visa, I don't have a contractor. People have to take you from face value.
Okay. I used this one because it was kind of paralleling the one that I would show after. So, but I can go back and look for the short axis.
You can show the first one, meaning that the valve is still coapting.
Yeah.
One that will determine better, at least some severity of the tricuspid. Do you have hepatic vein Doppler?
There might be, but it might not be ideally clear. But I'll double check on that.
Because that's your first shot. I mean, I don't know where you, at this time, I don't know how far you take in the case.
Yeah.
Right? And the first one has to be at least convincing, non-controversial. so that, I'm listening and my mind is back. You understand?
Yeah, got it.
I don't want distraction.
So I guess one format question is, would it be appropriate to interject some questions as you present them? Like, for example, here you could ask a question. Is this, you don't have to stop and with an answer, but you could say, at this point, this was called moderate to severe TR.
Do you agree? You don't agree?
In order for, is there sufficient data to support it? And then leave it open and then come back. So you start planting the question that you want to discuss.
Okay.
It really depends on what this case and what the format is about. The discussion is management of this case or management of severe TR, or trying to understand the pathophysiology of why is TR getting worse over time. It really depends. So you don't want to distract them from the main question.
Mm-hmm.
You understand what I mean? I mean, it's not a question of is this severe TR, yes or no. If the question, if the whole purpose of the case is a, it's an interesting situation here. Progression of TR and then working on the functional that that's going to bring something else to the equation.
So then if you don't want the patient of TR to be the focus, you can just say this was called moderate to severe TR by the interpreting element.
That's what she said. Right?
Even because we already had a whole session, like a whole presentation on how to evaluate and quantify TR.
So you're out of that. Or you should be
I
out
hope so.
of that. No, you should be out of it.
Then don't dwell on that. Those are the images you have, and that's what it's called.
Okay.
Okay. So we need a little better picture here.
Okay.
I think you could call it the top left image of 2D. You can see that in that view there appears to be very little coaptation.
There's still coaptation is very little, but
I mean, they're touching, but there's no overlap.
yeah.
So I would say the poor coaptation, the color Doppler is what's shown, and there's the CW, and it was interpreted as moderate to severe TR.
Okay.
Period. Inside of it.
Interestingly enough, throughout your presentation, the two clinical questions that always came back are tachyarrhythmia, right? Tachyarrhythmia and hypertension.
Yeah.
Nothing about truly severe tricuspid regurgitation.
Well,
Volume overload.
it-
Anything on the exam to
But-
point me that this is the issue.
But I guess that the only reason why we did not have that is because the patient is on thrice weekly dialysis. So we're managing her volume overload otherwise. So probably she doesn't have the time to develop those type of symptoms, which is probably why that wasn't ever the focus on the management of this particular patient.
But this is pretty common, that there's a lot of TR in the background that is not the clinical focus. The focus tends to be AFib because that gets the attention, it goes hot, it goes cold, and quite often dialysis, although being done 3 times a week, is not achieving a true dry weight because they stop until hypertension.
Yeah.
So the patient may be chronically volume overloaded. And we've had those conversations where you have to tell them probably, hey, you need to take out more volume because of
Do you know that? Do we know that? You give a clinical caveat throughout, right? Here and then there and then another 2 years down the line, once you see the progression here. But you never gave us this, I don't know if it is somewhere, but the clinical significance of tricuspid regurgitation. That's what I mean.
Mm-hmm.
And it's always heart rate and blood pressure as opposed to any lifetime effect. Right? And what's bothering me too is what's causing the RV dysfunction. I have no idea.
The final RV dysfunction?
Yeah. I mean, is this another event? Is this a TB event that has happened? What happened to a pressure? What happened to these other things? I mean, you rarely see a significant worsening of the RV. RV is the limit here, right? It is just pure PR without any other thing.
That's what I could.
RV function is
I think that's the implication based on the session. It's kind of normal ventricle severe TR, so it's guess. I mean, that's part, this is the discussion for the panel. Why does TR develop? So clear this, you start off based on the massive HA. Both sides over 100 points. Maybe that's chronic volume load with dialysis.
That was my guessing going through the charts because there was nothing noted about any type of acute a PE or acute event that could actually have worsened the RV function.
PA pressure estimate is about
50.
The RV function is about
This time?
Yeah.
I can't see the scale. You have to kind of put that scale, or, you know, another thing is, I mean, if it is 50 to start with, that may be something that has to be worsened, but you don't mention any PA pressure with an outpatient.
Okay.
Because to me, the big surprise is not necessarily the progression of PR, is really what happens with the right ventricle on top of that.
Okay.
And you may want to leave them off a little bit, that pulmonary hypertension was there to start with, but it's something very good PR and treatment with that further down. So I would mention maybe on this, instead of just emphasizing moderate to severe PR.
The pH pressure.
Right.
Okay.
So this is a 2-meter scale each, right? This is here.
It's 100, 200, 300.
Okay.
Again, the format's unusual because we're not asking questions on today, we're not asking Kevin, just your case. I think these cases are designed to be something to go back to when we discuss general issues around PR. One of the issues you hope to come up is looking back over the 3 or 4 that you present, was there an appropriate time for intervention that was specific to that? If you had normal RV function, suddenly there's terrible RV function, at some point should it ring, or catheter-based intervention, or something has been discussed. And when is the point of no return? That's often the big challenge, is what is the RV prevent treatment?
And going forward, you want to go forward. Fine.
No, I'm done. I'm just.
I would, the question is, what are you going to do? What's the puzzle of this case? Are we talking about relation? It looks like we're emphasizing relation of two sides. Some really discussion there. The question is are you going to do this? I mean, you need to kind of synchronize it with your analysis, right?
Yeah, that's what I was trying to get a glimpse of what other people were talking about. And again, we have an abstain, we have interventional, and we have previous to this discussion the technical points. So how to define TR, how to define the severity of TR, and what is the prognosis, and what are the implications. So my understanding of that was, given the title normal ventricles and big atria, my understanding was the connection between AFib and TR, and what's the implication of that. Normal size.
Well, here's what you might be summarize to 7 minutes and you have time. You could just summarize what you know in 5 points. So you started with severe LA dilatation, tricuspid annular dilatation, TR, normal function.
Mm-hmm.
A couple of years later, now you've got AFib, atria is even bigger, TR is clearly severe, but the RV is normal.
Yeah.
And now 1 year later, the RV is blown out, and everything's worse. So was there a window when something should have been done? And is that kind of
And also, what's the pathophysiology? Right?
Yeah.
I would leave it. This is where you come in, and the panel comes in to decide that. Because you find the skill in the patient, but I think it's really a wide open question. I agree with Steve. I would do after this that these are the issues of this individual. You start with modern PR, full cohabitation, you progress, and worsen RV function on top of that. And it is a puzzle. But
It is.
what's the pathophysiology? And how do you
maybe a slide before you go to your summary where you show data and graphic?
Just maybe just a table, year 1, year 2, year 3.
Question for this case. What is the likely pathophysiology of RV dysfunction and worsening TR? Was there an appropriate time for intervention or prevention?
Okay.
What is it? That sort of closes it and asks specific questions to the panel. So that you can do maybe the first case, they do 2 more cases before they get a chance to comment.
Yeah, that's exactly the issue.
The panel won't be able to write your comment. As you're presenting, folks can ask questions.
who are the panel?
So the 2 co-chair will be Professor Brebi from Paris and Dr. Patel from Boston. And then we have Michael Demore, Boston, Anyamvu from New York, Kandera, Milwaukee, And the other discussant will be Badano, Picard, Jay Hall, and Carlos Mestres from Abu Dhabi, and Nijazi from Qatar.
I think there are more panelists than the announcers.
Yeah.
All right, but you got to hodgepodge of things, so let them
Talk.
speak it out. But it's a good thing to kind of summarize it and also give us a feel. You started with the PA pressure, right? Give us a feel of the PA pressure.
After, okay.
Or, if it is really wide open, the last one which was, that, this PA pressure estimate could be actually underestimated because you don't know what the radiation pressure is like, right?
Okay. Thank you.
Okay, this is a case for fellows in training. I didn't expect this case to be accepted to begin with. It's a very minor kind of thing that we see in a day-to-day, everyday mitral regurgitation quantification errors by transthoracic echo. So this was a case, fellows in training cases. No, it's not oral, it's a poster presentation, which one of the other pitfalls of this poster, because a lot of these things were good images and I could have presented it better in slideshow, but these are still images, which makes it a little bit more challenging. So, it's a poster.
I know, but it's supposed to, they have provided a little something that you could show a video there, but they haven't done it.
No, and I'll double check with them, and I have all my images with me in any case if someone, I was going to keep my laptop with me and show people images if they were interested. Yeah. Yeah.
Importantly, you use the big M for the heart center pacemaker.
Yes, that's why that's the M's there. That's not Mawash, that's Methodist. Yeah. Yeah, I can. I'll take that along with me.
No, we're not buying you that.
Oh. Okay, so this case is pretty simple. It's a 65-year-old gentleman who presented to the hospital with recurrent admissions for heart failure. And unfortunately, in one of his hospitalizations, I was an intern at the time, and I'd seen him at some point in time. He was seen eventually because of recurrent admissions by our heart failure service, had an echo done which showed normal LV and RV function, was diagnosed to have grade 1 diastolic dysfunction. And at the time, because his symptoms were out of proportion, he underwent a right heart cath. So the first picture is the echo picture, which shows very trivial mitral regurgitation, figure 1A. This is the first echocardiogram that was done in the hospital. Then subsequent to that, he had a right heart cath, and those were his numbers. His PA pressures were, and wedge pressure was slightly elevated. That's the tracing of his wedge pressure. So this escape out? No, but if I escape out, then it loses everything. It's a Mac, so Mac's kind of funny. Let me see if I can do this. Mirror show? Okay. And then current slide. No, still. Now escape out. Okay, cool. All right. So mirror. All right, cool. So figure 1A is the first echocardiogram that he had done, and that showed normal LV and RV function. And I really had to look for this regurgitation kind of Doppler because it didn't really show a remarkable mitral regurgitation. Then these were his right heart cath numbers and tracing. And as you can see on the wedge pressure tracing, you really do not see a very tall V wave, which would have been suggestive of the etiology of why he had shortness of breath and heart failure symptoms. So he was then followed up in clinic again, and then In a clinical setting, he still had NHYA class 3 symptoms, was very short of breath, again, disproportionate to his echo, and disproportionate to his previous diagnosis, which was of that of grade 1 diastolic dysfunction. So at this point in time, a cardiac MRI was done. And unfortunately, I mean, that was the first test that was done after. And what was interesting was that he was. So the reasoning was maybe to diagnose any kind of cardiomyopathy and other etiologies that could result in shortness of breath. And then also, when this murmur was heard on examination, the other thought was maybe he has some kind of valvular issue that was not picked up on the echo. So let's proceed doing a non-invasive test, then doing a TEE first. That was the thought process. Yes.
Are you confident the gradient can be
Yes. Because I looked back at all the charting and everything, and even in my own intern note, it said it radiates to the axilla. So I'm going to go by what was documented. Yeah, that's correct. Right. Yeah, you're right. I can. Right. No, you're absolutely right. So, okay, I mean, I was going by what was documented, but I'll remove that. So this was the MRI. Again, the MRI actual moving images are much better and they show a profound amount of mitral regurgitation with this flail P2. But as you can appreciate here, you can see the flail of the P2 segment. And so after this, he also had a. Okay. To say where the flail is. Okay, I can put that arrow in. So then, as part of surgical planning, a TE was also performed, which showed this really eccentric wall-hugging jet, which kind of is what the title of my presentation is, a Quanda effect, which if you have an eccentric jet and through hydrodynamic effects, it can cause a wall-hugging jet that can actually make the actual MR jet very trivial on the transthoracic echo. So that's in the, I put that in the text, let me see. It was severe, Dr. Q. I'll put that in, the regurgitant fraction and everything. Yeah. Okay, yeah, I'll do that.
Okay, so this is one thing that we get in trouble.
Okay.
It's a dog in MRI evaluation. Okay. If you have a type 1 diastolic dysfunction, which means a low E and a high A,
Right.
you never, and it's a dogma, you never have the EMR.
Okay.
It's a dogma. It has never been broken.
Okay.
Now, the opposite is true. The specificity, okay, so the opposite may not be true.
Okay.
But if you have low E, high A, most of them have is more than most.
Okay.
Because by the time you get to EMR, you get a big regation going to turn into microgram. Your E velocities are higher.
Okay. Okay.
So you really need to review those echoes.
Okay.
To be sure, because the type 1 implies low E, high A.
Right.
Okay? And that, all you need is one echocardiographer that knows the business, passing by the poster, and getting you in trouble with that.
Okay. Yeah, no, absolutely. I'll look at that.
Well, it's kind of like this. That's why you need to go back and check.
Yeah, this was the first echo, but I'll look at it again. You're right. I'll make sure that's correct. Yeah. No, I'll double check on that.
Yeah, but don't change the data to make it consistent.
No,
If you review it, and it's still type 1, it's still a puzzle because I'm still a bit puzzled on the hemodynamics of this individual.
Right.
The severity of the symptoms.
Right.
Right? So conceivably at rest is much less impressive, or things have worsened over time. I don't know what's the time from the initial evaluation to the latter evaluation, or things at times progress. But, another thing, if you want to put it as a solving, as a case to solve,
Right.
I would put it just like you presented. Meaning the first image is from your transthoracic and then you did your MRI because of an issue.
All right.
You did a CAT, you did an MRI, and then I did a TE to figure out whatever it is. Because you're putting those together, you understand? And it just takes away, the story.
Curiosity. Okay. So I can. Right.
And that's not what happened.
Yeah.
So
Okay.
that's why I asked you, why did you want to do the MRI,
Yeah.
right? So I would put, this is one thing, one case.
Right.
You have to put it there. And if it was radiating to the gut, just keep it in the gut. Doesn't have to
Yeah. At least that was what was
doesn't have
documented.
to fit the dogma.
Yeah.
You don't have to change it just because the vast majority do. Particularly, what you are thinking.
At some point, post-operative. Prior to, I don't think so. I went through all his records. He was not in atrial fibrillation. Yeah. And then, okay, so then he underwent mitral valve repair with annuloplasty. And so this MRI is kind of like pre and post. That the first one is that shows the flail leaflet, and the subsequent one shows when it's post-repair, and that shows good coaptation without any flail. So basically, the point that we're making here is that mitral valve regurgitation, and we all know this, has pitfalls just from transthoracic evaluation, and sometimes even gauging the severity of how bad your mitral regurgitation may not be enough to look at just the transthoracic echo. And in these cases, your invasive hemodynamics may be helpful, but if you have a jet that's eccentric and it just directs towards one of the pulmonary arteries and not everywhere, it might may not see the tall V waves that we typically see with patients with severe mitral regurgitation. And in patients, if you suspect severe mitral regurgitation and you want to go a non-invasive route, then cardiac MRI is a good strategy. Although again, it's expensive, but one could argue that if you don't want to put someone through a transesophageal echocardiogram, then that's something that you could do first. And that's pretty much the conclusion. And
So somebody comes in, passes by, and says, I have no idea what this Covanda is. Can you tell me?
yeah, so it's basically a hydrodynamic effect where if you have a really severe kind of regurgitation jet, because of the hydrodynamic effect, the forces push the jet towards the wall, making it a wall-hugging jet instead of a central jet or jet directed in one direction.
You're saying the severity of the MR makes it wall-hugging?
Yeah, severity has to play a role, but you can have not as severe with Coanda effect as well. But it could also be a directional issue. Okay.
The one that is against the wall-hugging itself.
Okay.
You got to be careful about that because
The wall-hugging is
he may send you some pictures. Because, let me tell you something. I would take this case personally. If I want to put it together, I put it together for teaching of two things.
Okay.
Right? One, that in eccentric or an organic mitral regurgitation or ground mitral regurgitation, and the pictures are not degraded, you may miss significant amount of regurgitation.
Right.
And to take it as an education moment as to what Coanda is. You understand what I mean? Don't think, well, it's a wall-hugging jet, I lose momentum, et cetera, et cetera, et cetera. Just take it as a teaching moment so you could tell them what you know about
Okay.
Coanda effect itself and where does it mean from Colorado.
Okay.
That's
Yeah.
what I would do. So you have a lot of, you're quite verbose on, this. And usually when you have bullets, don't make them sentences.
Okay.
Make them points so people can read them very quickly. And it doesn't have to be, a full sentence, nice English sentence, really.
All right. Okay.
Because then if you have too much, if you tell me what do you have in those 4 or 5 bullets, there's no way I'm going to get the essence of it.
All right. Okay.
Okay, so research Coanda, maybe, believe it or not,
Uh-huh.
you may want to, under Coanda, you can put a title, what is Coanda,
Okay.
right? And so you get all the fellows just hovering around you. Right? I'm not kidding you, what is Coanda? And then a picture of
Okay, that sounds good. Okay, that's great. Okay, I can improve on it a little bit. Okay, thank you.